Case number 3, this is a very powerful case, and this is, some of, the reason why PT should be, getting into ultrasound so that we can really treat the root of the problem. Unfortunately, at times, physicians don't get a lot of time with patients. We're physical therapists. We can spend up to an hour evaluating that patient and doing special tests and even point of care musculoskeletal ultrasound and really figure out where their symptoms coming from. So this was a 68-year-old female that was referred via word of mouth to see me for chronic right knee pain and lower back pain. And she hurt herself over a year ago when she was doing trap bar, hex bar deadlifts at the gym. Past medical history, she's a very in shape lady, and that, past medical history is unremarkable aside from right knee osteoarthritis that was confirmed on x-ray. So the patient was seeing an orthopedic surgeon. The patient did have PRP injected, I believe, twice into her knee 2 months prior without relief, and the patient did spend several $1,000s out of pocket because these PRP injections are not covered by the insurance. The patient's imaging of the right knee x-ray did show advanced osteoarthritis. However, there was no imaging that was done on the lumbar spine or the right hip of recent history. Physical examination did reveal a marked loss of right hip internal rotation and flexion with pain with those passive and active range of motions, and also a positive right hip scour test. The right knee range of motion was within normal limits, and there was no pain reproduced with active, passive, or resisted motions of the right knee. Lower extremity dermatomes were intact. That should read from L2 through S2. Negative slump test and passive straight leg raise tests were noted bilaterally on the right lower extremity. So neural tension testing did not reproduce any sort of radicular symptoms. She had an absent right patellar reflex, and her left was +2, and bilateral Achilles tendon reflexes were +2 bilaterally. So we did some point of care musculoskeletal ultrasound, and as we can see here, the right hip in long axis is definitely not normal. I get my cursor here. So here we have the acetabulum. Here's the femur and the femoral neck here coming down. In long axis, we do have a short axis view of the bony irregularity. There's a bit of a joint effusion coming out here. And then we had a measurement. So the capsulosynovial thickness should be less than 7 millimeters. This lady kind of clocked in almost 10 millimeters worth of capsulosynovial thickness. So that's an abnormal amount of fluid. And there's a joint effusion here, which is coming from significant osteoarthritis of the right hip. And we can appreciate all that significant cortical irregularity. We do some, myself here at the office, I do a diagnostic musculoskeletal ultrasound in addition to EMG and nerve conduction study testing. And in the state of Pennsylvania, it does say that is in the scope of the physical therapist, as long as we have a referral from a physician. So I did call the orthopedic surgeon, requested an order for an EMG and nerve conduction study. And actually, we did see electrodiagnostic evidence that there was some radiculopathic process going on. So here's kind of what we found. Within this young lady's EMG and nerve conduction study, we did have fibrillations and positive sharp waves in her lower lumbar paraspinals, and that there really was not any evidence of an underlying polyneuropathy, that her sensory nerve conduction studies were normal. So this is a nice case that's combining both the musculoskeletal ultrasound and the electrodiagnostic testing into a case. And how did this all manage, how did these modalities change this patient's medical care? We referred her back to the physician. We did get an x-ray confirming the significant osteoarthritis of the right hip. The EMG nerve conduction study, interestingly enough, was pointing to a lumbar radiculopathy as well. That patient has now been sent to pain management for her lower back, and she's still actively receiving physical therapy. Interestingly to note, there's bone-on-bone arthritis in both the right hip and the right knee. And what helped this lady feel better was actually treating her lumbar spine. So it just goes to show you that, there could be times that imaging may show arthritic changes or degeneration, but that might not be where the case is or the patient's symptoms are truly coming from. So this lady is still receiving physical therapy. We're trying to avoid any unnecessary surgeries, and I believe she's going to be getting a lumbar epidural injection in the not too distant future in conjunction with her hands-on physical therapy that we're providing. She was very grateful for the use of the ultrasound to try to find where the root of her symptoms were coming from. And then also the electrodiagnostic testing was a very powerful adjunct to this case.